So the implication of your question is that the DSM-4 discourages people from entering treatment.
Can you see that?
I, in my practice, don't see that consequence occurring. What could it occur? I think it is a possibility. Jim?
I'm sympathetic with your concerns. I think people come into treatment knowing they'll get a DSM-4 diagnosis, and that's just how mental health culture operates these days. So they still come.
Yeah.
But it's sad that they come for the service they come for sometimes. So I am very sympathetic to what you're saying. I'm in agreement with it. Phil may think it's a small issue. I think it's a big issue. But it's too bad it's such the standard these days that few people are describing it as a big issue. And back to something else. There are, of course, limits of conversation. Mm-hmm. And if someone has a very serious condition or is seriously troubled, I have no hesitation at all about referring them to a psychiatrist when conversation is met its limit. But I don't think we need a 600-page manual to do that.
All right, these have been great questions. Who has more questions? Nick?
Yes. Do counselors as a profession, do we need the DSM to justify our own existence?
Okay, do counselors as a profession need the DSM to justify our existence? And I think it's Dr. Hansen's turn this time.
Oh, okay. Maybe. Next question. We're in a culture that's a strongly DSM culture. You could be right that counselors need the DSM in order to operate within it, in order to have any status and prestige in it. But it wasn't always that way. It used to be that the DSM hadn't overtaken the universe. Now that it has, we may have to use it to operate in that universe. We could have, when it was first introduced, said, we're a relational profession. That really doesn't have anything to do with us. No, thank you. It's an interesting thought experiment to see where the profession would have gone if we would have done that. But we may need it for professional status as well as to get paid.
Jim is right. We need DSM-4.
You need about everything, right?
Okay. More questions?
I'm curious, my name is Sonia. I'm curious, even earlier today, I think she's here, but sitting in on about combining the medical world with mental health world, and something that stuck out to me was the idea of looking at a symptom and identifying, the neurotransmitter attached to that symptom and treating the neurotransmitter. So my question, doing that is, if we're still, I'm kind of having a hard time going with this because I just was learning about it today. But if we're labeling a person, can't we, I know we're labeling the diagnosis, but what's the difference? Can't we just take a look at their symptomology and say, oh, you're having these symptoms, these medications could help with those symptoms, instead of telling them, okay, you have depression or you have bipolar disorder?
Okay, so the gist of the question would be, can we treat the symptoms without giving it a name?
Yeah.
And associate symptoms with neurotransmitters and leave the name out of it?
Yeah.
Okay. Dr. O'Dwyer, you're first.
Theoretically, we could, because it's the symptoms that matter. It's the symptoms that bring the client to treatment. There is where the pain is, there is where the heart is. And so, in theory, we don't have to use the diagnostic categories in the conversational engineering. But however, when we converse with colleagues, we need to have clear, agreed upon language. And so we may say this client has schizophrenia, this client has major depressive disorder, whatever it turns out to be. So in theory, you're right, we could do that.
Yeah, I agree. I'm not a psychiatrist, of course, but I know they have a very limited class of medications. And I hear your question is fundamentally saying, couldn't we just organize a system based on which medications worked for which symptom classes, rather than having all these discrete, hair-splitting diagnostic categories? That's been proposed, and I think that's a reasonable idea. And recall, I don't have a problem with psychiatry using the DSM if it allows them to help people. If that's an instrument they can use to help people, that's fine by me. I don't see why they need all these hair-splitting diagnoses instead of about 5 or 6 big categories, because that's all the categories of medicines they have, but I'll leave that to them. For counselors, we don't have specific treatments tied with specific descriptive psychiatric conditions. That's why it's mostly useless for us.
Just, if I might add just a sentence to that, Jim. But the fact is, we work with psychiatrists every day. The clients that we see are clients they see. And that's one of the reasons why we need it. Another of the reasons we need to have that uniform language.
More of my clients see dentists than do psychiatrists, but I don't consult dentists regularly.
What other questions are out there? Nate?
This question is for Dr. O'Dwyer. I think that Dr. Hansen mentioned several points about this. DSM is evolving because they vote down several diagnoses, and also it's cultural bound, so it's not universally objective. Can you address that more specific to those points?
So the question was, the DSM is evolving and it's culturally specific. And you would like Dr. O'Dwyer to address those points. Did I get your whole question? Perfect, thanks.
You're absolutely right. The DSM is evolving. It evolved from 1, 2, 3, 4, and now we're waiting for number 5. And going forward, we should have them coming more frequently to reflect research findings with regard to a variety of conditions, so that it helps us more accurately describe what clients are experiencing, and hopefully have sufficient field trials that would suggest ways that might help these clients deal with those conditions. The question of culture, our culture is like our shadow. We can't get away from our culture. So no matter how we approach DSM or any classification model, culture will be represented in our point of view. So I don't see any possible way that we can avoid reflecting our culture at a time, which is a positive thing as well as a negative thing. Negative in the sense, if you're looking for uniformity and something that never changes, well, culture changes. And so we may think at one time something is abnormal, and at another time in our history see it as less troublesome.
So you're really saying that DSM is nothing that can be universally objective, like our temperature?
In terms, and that brings us back to the scales again, the bathroom scales. See, when you're talking about the human experience, it is enormously difficult to reduce it to the measures on a bathroom scale. We're much too complex to reduce it like that. However, that doesn't mean that we cannot have good insights into neurotransmitter systems and how they impact behavior, how traumas experienced at one time or another may impact people in the future. But to seek to find something like a bathroom scales is looking in the wrong direction when you're looking at human behavior and human emotional experience. And the DSM-4 does not purport to do that. And the categories in the DSM-4 are not based upon any such scale. So it is essentially a red herring to talk about such precise measurement like a bathroom scales, and then apply it to the DSM-4, and of course the DSM-4 will be found wanting.
Just to go back to the bathroom scale. I wasn't trying to reduce human experience to a reading on a bathroom scale. What I was trying to illustrate is that a criteria of any categorical system is that it categorizes accurately. And I was simply using the bathroom scale as an illustrative metaphor of something that you would throw out if you found it didn't measure accurately, the same as we should do with the DSM. Now, Phil talks for counselors. You see, Phil talks a lot about neurotransmitters and things like that. And that's all fine and good for psychiatry, and I wish them well in terms of making progress in that area. That is not my area at all. Okay? My area is trying to help people using relational methods. So if psychiatrists can make progress with neurotransmitters and medicines, good for them. If they can help some people using compounds based on that conceptual framework, good for them. Is the DSM good for us? I can't see why. And no matter how many times I listen to Phil talk, I try to get it every time. I really do, but I